Welcome to Good Tech, Compassionate Healthcare, an AMS healthcare podcast that explores the convergence of technology and compassion in healthcare. We host conversations between leading researchers, scientists, and healthcare providers as they confront the challenges threatening our current and future healthcare system, especially in the face of the pandemic. We see an incredible opportunity for digital health to innovate medicine and clinical care, healthcare education, home care, and beyond. That said, we hope to foster an open-ended discussion about how to integrate technology into the healthcare system in a way that enhances and doesn't diminish compassionate care. Ultimately, improving the experience of patients, caregivers, and healthcare providers alike. If there was ever a time to uphold compassion as the bedrock and guiding principle of healthcare, it's now. Join us now to explore Good Tech, Compassionate Healthcare, brought to you by AMS Healthcare. This conversation focuses on exploring technologies and their impact on compassionate healthcare, and features Laura Desveaux, a behavioural scientist at Trillium Health Partners, and physician and scientist Amol Verma from St. Michael's Hospital.
Amol, I'm so excited to sit down and have this conversation with you today. I welcome any opportunity to do so, but keeping in mind that others will be joining us virtually along the way, I thought we should take a moment to stop and introduce ourselves.
Absolutely, Laura. It's so great for us to be able to sit down together and talk about digital technologies and how they affect compassionate care. So I guess I'll start with the unhumble self-introduction, which is always a little awkward, but I'm an internal medicine physician based at St. Michael's Hospital in Toronto, and I'm also a scientist. I'm a health services researcher, and my focus is on using electronic clinical data to understand the quality of hospital care for adult patients and find ways to improve the care that's delivered in hospital.
I'm clinically trained as a physical therapist, but no longer practicing. And as yourself, I imagine I really value that clinical lens, which I bring to my work as a scientist and health services researcher. So I'm the scientific lead and learning health system program lead at Trillium Health Partners. And in my scientific work, I'm an implementation scientist and behavioral scientist. Unpacking the jargon, what does that mean? I'm interested in understanding how and why things work with a view to helping the system understand how we scale up and operationalize what evidence tells us are strong strategies for improving care. And from a behavioral science perspective, it's really about understanding how and why people make the decisions they do, so how they think, because as we all know, people are at the center of healthcare. And if we don't have our eye on how people are operating and what we can do to support quality care and compassionate care, then we won't achieve our objectives as a system. So that's really the lens that I'll bring to our conversation. Very topic agnostic and methodologically specific.
So I will try not to be self-conscious that you're analyzing how I'm thinking and why I'm acting the way I'm acting.
I mean, it's all about curiosity and understanding creative minds. And I think yours is one of the best ones I could have as an example.
So we should maybe start with a bit of I don't think it counts as a disclosure, but a bit of background for listeners that you and I have had the occasion to work together in the past, which is exciting to be able to actually talk about projects that we're not specifically collaborating on. We both are collaborating around a study to understand the way physicians receive clinical feedback or practice feedback. And that relates to work that I do as one of the co-leads of Gemini, a hospital research and analytics collaborative. One of the facets of that work is taking clinical data and providing practice reports back for physicians, which gives them some information about the care that they're providing. And your expertise around behavioral science and implementation science really lends itself nicely to trying to understand how can we use the data that's embedded in electronic clinical records and make it meaningful to clinicians so that they can act on it to improve the quality of care that they're providing.
I'm really glad you brought up that project, Amol, because it's close to my heart. I am interested in the application of implementation in behavioral science to help improve performance. And that collaboration with Gemini is really about helping individuals improve their performance through the clinical decisions they make. And what's great about the contrast between that and my AMS project as a fellow is my AMS project is more centered around how we can use implementation in behavioral science to help the system improve its performance. At a high level, what my AMS project is looking at is whether and how the use of digital technologies in the primary care sector has shifted the nature of the healthcare professional and patient relationship. Once we have a sense of how that has shifted, we're then going to look forward to understand how the building blocks of people and technology can come together to enable compassionate care. So it really comes from a place of recognizing that there is no one size fits all and that there are multiple pathways to help different individuals with different priorities and beliefs and experiences engage in a compassionate care relationship. So the hope is that the output of that project will be sort of a series of roadmaps or menu items. Those that know me know I love analogies that relate to food that can help providers, patients in the system understand how we combine some of these components to get at the system experience we're looking for.
And so what are the digital technologies?
So technology agnostic, but any platform or technology that enables synchronous video contact, so in-person visual contact with your provider, as well as any platform that enables asynchronous connection with your provider. So that could be secure messaging, which could take a variety of forms, as well as remote monitoring platforms that allow you to exchange information with your provider, in theory, real time or asynchronously, and sort of have that direct line connection and whatever it looks like. And to be clear, those are some of the common categories we're aware of, but it really is a project that has inclusion criteria as opposed to strict exclusion criteria so that we can really be comprehensive in understanding the tools that might be available to us to realize compassionate care moving forward.
That's really interesting. And so it sounds like the common thread is you're thinking about how novel communications technologies are allowing for different types of clinical interactions that maybe we didn't have before, and then thinking how that shapes the interaction between clinicians and their patients.
Yeah, there's an underlying hypothesis there from my perspective that when you introduce a new modality or a new mechanism of connection, it will inherently shift the way both patients and providers occupy their roles. So how providers carry out their clinical work and how patients engage similarly with their care. And preliminary data suggests that that's a reasonable hypothesis to have, but it's about validating that and then moving forward from that to understand whether and how that's happening in line with the realization of compassionate care, or more likely, whether there is tweaking to be done, and more specifically, how we would need to tweak to better pursue our goals.
It's really interesting to think about roles. I mean, as a clinician, I know I don't explicitly usually think about my role. I kind of just inhabit this professional persona, right? And then take care of patients in, truthfully the way I was trained, but which ultimately just ends up being kind of a bit of a patterned kind of response to given scenarios, right? But it's interesting you think about even patients as playing a role. And I think about the times that I have been a patient or a caregiver to a patient. And it's funny, I don't usually think about myself as playing a role in that situation. You're usually just kind of going in saying like, I need care, right? I need help. But of course, we kind of are playing a role. You're telling a story. You're trying to get something from your care provider. So it's interesting to just frame that as almost like a performance that's happening between two people in this exchange.
I couldn't have said it better. You're on your way to an honorary behavioral science degree. That what you're pointing to is the reality that behavior is both automatic and reflexive. And we're often, by very definition, not aware of what is automatic or habitual. And so part of what I'm hoping to unpack in our work is shining some light on those things that have become by necessity automatic so that we can then actively reflect on whether or not that's still serving the goal, or whether or not we need to reimagine the way that we provide care or interact if it is mediated by a digital technology. And similarly, I think the work that you're doing with your fellowship provides an equal platform to think about what that might mean for reimagining roles or how healthcare professionals carry out the work that they do?
Yeah, the thing that I was thinking about, sort of bridge maybe between our work, is a component related to mindfulness of practice and how that shapes your role. So my project is implementing an artificial intelligence early warning system in hospitals. So we know that patients in hospital, they come to hospital because they're sick. Many patients end up on a medical ward. And of the patients who end up on a medical ward, a portion of them will deteriorate and then require intensive care, or maybe even get so sick that they die in hospital. What we know about that process of clinical deterioration is that the whole role of clinicians is to try to intervene and prevent that from happening. One of the major challenges in hospital, particularly when patients deteriorate to the point of requiring intensive care, is that we as the clinicians haven't recognized early enough when a patient starts to deteriorate. And so the leading cause of unplanned transfer into an intensive care unit is a failure to recognize clinical deterioration. And you might imagine that there's a lot of reasons why this might occur. You know, clinicians in hospital are super busy. They're taking care of dozens of patients at any given time. They have many competing demands. The signs of early deterioration might be subtle and may not be immediately apparent to clinicians. And so this problem actually presents an opportunity for artificial intelligence, which is so good at recognizing patterns. And so the question is, can we teach an algorithm to recognize when a patient is deteriorating and predict the people who are at high risk of future deterioration so that then clinicians can intervene earlier? And so we've developed an early warning system that does just that uses artificial intelligence to mine the information that's in the patient's electronic clinical record. And every hour it updates a risk prediction and determines which patients are at high risk of deteriorating. And that artificial intelligence model, based on the research we've done at St. Michael's Hospital, is about 20% more accurate than the physicians themselves at identifying patients who are at high risk. And so we've now deployed this tool that runs every hour. We call it Chart Watch. I like to think of it as sort of a guardian angel in our electronic medical record that is keeping an eye on all of the inputs that are happening for patients. So their laboratory test results, their vital signs. It takes some information about the patient's demographics, and it puts that all together using machine learning to generate a prediction every hour about which patients are going to be high risk. We communicate those risks to the frontline clinicians, to the nurses and the physicians, so that they can reassess high-risk patients and be more mindful and think about their role. This comes back to kind of what we were talking about before. Think about what they could do to intervene for those patients to prevent future clinical deterioration. And the whole point here is to focus their attention on higher risk people early enough so that maybe they can intervene and prevent future deterioration.
Not surprisingly, I have so many questions because of how interesting that project is. And I think it's such a more practical use of our time for me to apply my skill set and thinking to this. And hopefully people enjoy listening along as we sort of unpack. But the first sort of frame that I want to put on the table is that for any behavior to happen, there are three precursors that interact with one another or satisfy conditions that need to be met. You need to have the capability to perform the behavior. You need to be motivated to perform the behavior, and you need to have the opportunity to do it. Now, in healthcare, I'm actually going to take motivation off the table for this conversation because it's pretty much assumed. Healthcare professionals are in their roles to provide the best possible care for their patients. So they're inherently motivated. You also mentioned the sort of cognitive load and workload of healthcare professionals. And one of the upsides of AI is that it helps add to the capability part of the equation by taking some of the work off of the healthcare professional's plate. So it does some of that legwork for you and helps build in the capability to detect that deterioration when we otherwise might not be able to pick it up. And one of the other things that's great that you just described is it actually also builds in opportunity by flagging that deterioration to the care team so that they can act. Off the bat, from a behavioral perspective, it seems like the building blocks are there. So my question to you as we sort of jump off is whether it's what you've observed or in your direct experience as a physician, how is it received that something for all of time that physicians and nurses and others have had to do on their own, how is it received when all of a sudden there is external support or a new system that can support part of that role? Is it a relief or is it hard to wrap your head around?
It's a great question. I mean, this project, I think, started years ago. So 3 years ago, we had the idea to start incorporating artificial intelligence into our clinical care and thinking, okay, how can we design a system that's going to be useful? And we started by asking the frontline care providers, the physicians, the nurses, the administrators, and patients and families within our hospital's patient and family advisory group, what is important to them? What could artificial intelligence predict that would improve the quality of their care? And through a series of discussions, we landed on clinical deterioration as the first priority that we wanted to focus on. You know, what's more important than death and critical illness, right, in hospital? And so that's where we started. And I think so we started with something that people cared about, and that got buy-in from the beginning. The second was that we co-developed, co-designed it from the very beginning. I'm embedded as a physician within the group of physicians. We had fantastic senior nursing colleagues who helped us co-design it. It was really developed with a group of clinicians, hospital administrators, as well as an interdisciplinary group of data scientists, information technology experts, data engineers, and then with advice and consultation with patients and families. From the get-go, we were thinking about engaging those end users, to use the jargony terms, to get buy-in, to make sure people trust the tool and would be willing to use it. And along the way, we've tried to think about how do we build that trust as we're building this program, right? How do we build that engagement so that once we launch, people actually do want to use this tool? To answer your specific question, there were quite a number of questions that came up along the way. Very early on, 2.5 years ago, we held a divisional retreat amongst all of our GIM physicians where we talked about this project just as an idea at that time. It was very germinal. We shared it with our colleagues and we answered a lot of their questions around how good would the model have to be in order for me to use it? What do I do with these predictions once I receive them? Can you help me understand how the model is working? How do I deal with something that I don't understand why it's making the predictions it makes? So we got a lot of questions along the way, and we have tried to answer them and design the tool with the people who are going to use it.
That's fantastic. And it was so great listening to you walk through that because you sort of painted a picture of people redesigning their understanding of their role and sort of actively working through how that role might shift if you introduce AI and what the sort of requirements are from an acceptability perspective in order to facilitate that shift. And I love that you started with the question of how do we design a system that's useful? Because if you aren't starting with a problem that people care about and a concept or a solution they buy into, you won't have that motivation on their end. That process may seem common sense to those that are in healthcare and working directly in patient care. I think it's never a lost moment to articulate it as clearly as you did to help people understand what that roadmap looks like. And equally, I heard sort of the iterative nature of that process and what sounds like a very clear commitment to the process. And one of the things that I've seen time and time again in the evaluation of digital health technologies is that it's not a switch you flip, and that transformation doesn't happen overnight. When you see it done well, there's really that upfront investment of building credibility and alignment with end users, and in this case, the clinical team, and sort of the appreciation that to really make something part of routine care, you need to have that coherence or that alignment. Then you need to have cognitive buy-in. And by that, I mean that people need to be presented with and react to the technology, in this case, the AI, and start asking questions about, well, where is this coming from? How did it arrive at this number? And they sort of, in a way, learn alongside it. And once we allow for that process to happen, then people start acting on the intel or utilizing that solution. So I'm wondering if you are in a position to speak to that last piece of what you've observed or what you've personally experienced in terms of putting the insights from that algorithm into practice.
We have, fortunately, have had some experience. So we launched the tool in August of last year. And so now we've had it actively functioning on our medical wards at St. Michael's for the last 6 months or so. And we've had, fortunately, a really positive early experience. The first is from the clinicians who are using the tool. I think because they were so heavily involved in designing it, we were able to incorporate it so it integrates pretty seamlessly into their existing previous workflow. As a simple example, we send email alerts to our charge nurses, and we send those alerts for the high-risk patients, telling them, what is the risk status of every patient on your ward. We send it to them to time with the time that they usually are doing their nursing shift assignments for the next shift. So they're assigning which patients are going to be looked after by which nurses. And, just as a sign of the heroism of nurses, this is like 3 a.m. It goes out at 3 a.m. because our overnight nurse is, taking that time in the middle of the night to figure out what's the care going to look like the next day, right? So twice a day we send that email, and it comes to them right when they're starting that task. And it's laid out in a way such that they can use it to actually do their assignments. And then they can make sure that no one nurse has more than 2 high-risk patients, right? So they can allocate the load of patients to nurses. So it's been designed to integrate with the existing clinical workflows. And I think just from a global perspective, the clinicians have really appreciated that. And so it wasn't a disruptive technology in the negative sense of the term when it came into practice. I think the second part is there was a certain kind of buzzworthy or intriguing aspect of this. It's new, it's a shiny new toy on the ward. And I don't mean the use of the word toy in any kind of pejorative sense, but it's this newfangled thing. And so there was a certain amount of interest in using it and embracing it. And we heard from we're a training site. So a big part of the people who will be using this tool are resident physicians, right? Trainee physicians. And we heard from the residents that they were really excited about it, that they often wondered, how does the model know what's going to happen? There were some case examples where the model had predicted that a patient was high risk. So as per our care pathway for high risk patients, the resident physician went to reassess the patient at the bedside, did a full thorough assessment, and actually couldn't figure out what was wrong with that specific patient or whether they needed to change anything. But then 3 hours later, that patient suddenly began to deteriorate. And because that resident had just done a thorough assessment, they could quickly act. They quickly involved the intensive care team, and they were able to smoothly transition that patient into the intensive care unit. And the resident's reflection was, had they not been proactive, there was a reasonable chance that that patient would have had an arrest on the ward, would have gotten so sick so quickly. And because they hadn't already done that pre-work to respond quickly, they wouldn't have been able to prevent that event from happening and move it into a more sort of controlled environment in the intensive care unit. And so, their reflection was like, how did the model know, right? And that kind of gets out word of mouth, right, amongst colleagues. And of course, we also hear about misses, like the model is not perfect, right? And we have to keep reminding our colleagues the model is not going to be right. In fact, 2 out of 3 times the model will not be right by design. 1 out of 3 high-risk patients will actually need intensive care unit or may die, which means 2 out of 3 times it won't happen. And so we had to really train our colleagues, our workforce, to understand that and not be upset when the model wasn't perfect, right? I still get emails saying, hey, I had this high-risk patient that the model didn't flag and they ended up going to the ICU. And I appreciate that. And the model will keep learning and hopefully getting better, but the model's not perfect. And so I think managing expectations has also been an important part of the process.
Not surprisingly, Amol, there were several things that were interesting about that. And one that I don't think we'll have the time to unpack, but I did want to highlight is my curiosity around how technology shapes the way we provide care and what it means for either learning or relearning how to do that. And you highlighted the residents who, at least at your hospital, are sort of being trained with these models. And it will be interesting when it is appropriate to do so to reflect on how it is different learning this from scratch versus the implications for relearning how you provide care alongside technologies. In that vein, sort of when I think about technology, it's a little bit more granular in terms of breaking it down into the functions that technology offers. And there were two key ones, although this is not meant to be a comprehensive list, that I heard from you. And the role of the AI algorithm is not just helping identify patients at risk, but also you pointed to a function of helping to allocate resources appropriately, which, I mean, I'm sure any charge nurse or any hospital administrator or system administrator would love insight into how we better organize or deploy the resources we have. But I'd like to turn the conversation specifically to something you didn't mention, but that I sort of hear is inherent in this. And that's the function that this technology might play in enabling compassionate care, specifically with relation to patients and families. So I wonder whether you've either seen in practice or have thoughts about whether the insights gained as a professional allow you to, or whether the insights you gain as a professional support the communication you have with patients and or family members about what you're learning and how you are responding to that information, or whether it even just frees up the sort of cognitive space for you to devote more time to connecting with patients or families, whether it's in relation to the risk prediction or not.
Yeah, I'm drawn to a story of a patient that I cared for before we started this project, which was one of the things that actually inspired me to do this work, which was a patient who suffered unexpected clinical deterioration in hospital. You know, I had some debriefing with their family members afterwards. And one of the things that they told me was their loved one had passed away suddenly overnight and through the next day. And they had stayed by the bedside till 3 a.m. and finally decided to go home. And they said, we never would have left if we had known that this person was going to get sicker overnight, right? And it was something that just sort of really touched me and made me think that we can do better, that we have the ability. One of the things that we as humans do most poorly is predict the future. And one of the things that our artificial intelligence tools might be able to help with is specifically that thing. And I think compassionate care has to be at the heart of the reason why we're doing any of this, right? And I think of compassion broadly. So first, it is in the way we interact with our patients and their families. And a big part of that is helping them understand what to expect, helping them, even if they have to expect the worst, helping them through that journey. That's a big part of what we as care providers do. And I think a tool like this really can help us have more informed discussions. The second is to provide care that is concordant with a patient's wishes and goals, right? And those conversations take a lot of time. Understanding what are someone's values, how would they want to be cared for in the context of critical illness, the so-called goals of care discussion. And as clinicians, we don't have the time to have hours-long conversations with every one of our patients. But if the model can highlight people who are at real risk, we know that, I should take the time in this context. And so that's actually one of the very first things in our care pathway is establish goals of care for high-risk patients through detailed conversations with the individual or their loved ones or substitute decision makers, right? And I think that's one of the major benefits. One of the things I'm not sure if I specifically said is the model is designed to predict clinical deterioration 24 to 48 hours in advance. So it gives us 1 to 2 days of time to act, to understand how to care for patients and to inform patients and their families. The third thing I'll say about a broad conception of compassion is, of course, compassionate care is high quality care. And so if I am being more attentive, if I am able to intervene earlier, if I'm able to prevent clinical deterioration, that's an important part of providing compassionate and excellent care. So I think there's a communication piece. There's also a quality piece. And finally, one of the nice things about having a model like this is also the ability to deliver reassurance. So let me tell you a story of a patient I had who was very unwell, had spent a lot of time in an intensive care unit. And when the patient came out of the highly monitored setting of the intensive care unit, you're always strapped up to a monitor. You have a nurse at your bedside almost 24/7. And that's a very reassuring thing for that patient and their loved ones, right? I'm constantly being watched. And then they come out to a medical ward where you have maybe a 4-to-1 patient to nurse ratio. You're not constantly on a monitor, but you have your vital signs checked every 4 hours or every 6 hours. That patient and their family was coping with a lot of anxiety of no longer being watched so carefully. And I was able to share with them, we actually have an artificial intelligence tool that's watching you every hour and telling me when you're high risk. And actually right now that tool is telling me you're low risk. You have a less than 1% chance of having a bad thing happen to you in the next 48 hours. And I think it helps the wife of my patient sleep that night. And so I think there's real opportunities for providing much more compassionate care that's digitally enabled. And of course, these tools aren't perfect. And so we have to have this conversation with our patients in, cautious terms. I'm very optimistic about how this can help us provide better quality and more compassionate care.
Amol, I know I'm not the only person who's going to have this reflection as others listen to this conversation. And I know you are not the only one with these qualities, but I'm so grateful for the care that you provide and that your perspective is one that is part of developing these solutions, because it's clear that although compassion has been explicitly considered in the development of this algorithm, I'm also quite confident there are ways in which it was just implicitly brought in because of the way you and your team think about providing care for your patients. So just wanted to make sure I took a moment to recognize that, especially because of the challenges and pressures that our system is under right now. Those stories were so powerful because you highlighted two gifts that are arguably the most precious to sort of patients and families. And that's the gift of time and the gift of reassurance. And as I think about next steps, not just for your work and mine, but the field more broadly, I would encourage everyone to think about whether and how the digital technologies that you're working with contribute to either time or reassurance or that type of compassionate wraparound that patients ultimately want to experience as part of their care. I wonder, this is not my area of expertise, but I wonder when we have more robust patient-generated data in our EMRs or systems, what that will mean for how quickly these algorithms can actually be patient-centered. And it's great that the work that you're leading is sort of building the foundation or framework for what a functioning model looks like so that it's almost a plug and play, not to be reductionist, and we can immediately leverage those algorithms once that patient data is available. And for me, as I think about what is my area of expertise, it really is about, as much as we need to understand the what of a given technology, so its functions, the form it takes, and how it works when you plug it into clinical workflows and how it needs to work to achieve its aims. It is really about the how and being very clear about that. So how does this technology or its components enable better patient care? How does it contribute to compassionate care, both in terms of the delivery from the health professional side and the experience from the patient side? One thing we didn't talk about a lot, but that I personally don't want to lose sight of, especially at a time when burnout rates are so high among healthcare professionals, is being clear that technologies in whatever form they take allow healthcare professionals to do what they do best and deliver care in the way that they want to deliver it. Because I have never met a healthcare professional whose number one priority is not providing the best quality care they can. And I imagine that as we start to develop technologies and systems that support compassionate care, that evidence in and of itself will be rationale enough for providers to rethink the way they do things, because anything that enables them to do vocationally what they set out to do is something worth buying into.
Yeah, I mean, thanks for all of the amazingly kind words you said there. And I think it's exciting to see organizations like AMS who are supporting the work of bringing digital technologies into healthcare in it with a focus on preserving compassion, and not just preserving, but enhancing compassion, the humanistic qualities of care that are so essential. And I do believe that in the best possible, brightest future of the implementation of AI and other digital technologies, it is a more humanistic care system. It is a more compassionate healthcare system. I also believe that there's a flip side where it's possible for these technologies to take us away from humanism and towards a more patterned and algorithmic care that is less compassionate. And that's why I think it's so important for the application of these technologies to be done with support from organizations and scientists who are thinking about how we can do this in the best possible way. So we achieve sort of the glass half full version of the future. That at its core, I think to what you said, it's an interdisciplinary endeavor. It requires behavioral scientists, implementation scientists like yourselves, who have that expertise to help us do this properly. It requires frontline clinicians. It requires ethicists and philosophers and technologists and, data scientists. It's really a whole team effort. And I think, with our specific project of ChartWatch, just an enormous number of people involved. And of course, thinking about how to ensure that the voices of our patients, their family members, are front and center as we develop these technologies, particularly the ones that are patient facing is so important. And importantly, this conversation somehow, maybe because of your incredible skill as a behavioral scientist, morphed its way into you asking me questions or making comments and me coming across as if I know what I'm talking about. And I'd like to say that this whole process has been incredibly iterative, and we're still learning a lot along the way. And so if I came across as being more sure than I am about any of these observations, that's not exactly my intention. But I think it's been a team sport, and I'm really excited for the future of digital technologies and how they can enhance compassionate care.
Yeah, that seems like a pretty good note. Boom.
Thanks so much for the conversation, Laura. It was really nice to get to chat with you and to pick your brain on some of the behavioral aspects of this work.
Yeah, it's been a pleasure. And I look forward to not only our work, but the work of the AMS fellows more broadly now and in the future with innovation in service of compassion and the heights that it will take our healthcare system.
Thanks for joining us for this fascinating conversation on technology and its impact on compassionate digital care. And a big thanks to Laura and Amol. Remember to check out our book, Without Compassion, There Is No Healthcare. Thanks for listening, and join us next time for AMS Healthcare Conversations on Good Tech, Compassionate Healthcare. AMS works to advance a Canadian healthcare system through innovation and technology while remaining rooted in compassion and our medical history. They convene networks, develop leaders, and fund crucial activities in medical history, healthcare research, education, and clinical practice. Their work helps improve care for all Canadians. For more information, visit amshealthcare.ca to access their wealth of resources and view their funding opportunities. AMS Healthcare has recently published a best-selling book, Without Compassion, There Is No Healthcare, available wherever you buy your books. A series of articles based on this book are available on healthydebate.ca.
This podcast was produced by Michael McDonnell, music by Carlo Cruz.